This is not medical advice. If you have a fever, severe pain, or symptoms that are getting worse, go see a doctor. But what you are about to hear is what doctors in 17 other developed countries recommend you try first. Before you pay a $2,600 emergency room bill. Last year, a woman in Texas walked into an ER with a burning sensation when she urinated. 8 minutes with a physician, 1 urine dipstick test, a prescription for an antibiotic she already knew she needed. Total bill, $347. The same condition in Germany is addressed with a first-line protocol that costs under $1. No appointment, no waiting room, no bill. The difference is not medicine. The difference is what the system decided you were allowed to know. This video is about 5 conditions that together account for more than 40% of non-emergency ER visits in the United States. 5 conditions that every nurse practitioner knows a first-line approach for. 5 solutions that cost under $1 each, backed by peer-reviewed research from the National Institutes of Health and the American Academy of Neurology, and 5 reasons the American healthcare system has never had a financial incentive to tell you about any of them. Welcome to Dr. Phillip's Forbidden Files. If this kind of knowledge matters to you, hit subscribe and the bell. This is where we dig up what the system buried. Before we go into each condition, I put together a complete reference guide based on everything in this video. It is called the Dr. Phillip's Forbidden Files Complete Vault. Inside, you will find the full dosage protocols for each of the 5 interventions with sources cited from NIH and peer-reviewed journals. A symptom checklist for each condition so you can identify exactly when the first-line approach is appropriate and when you must go to a doctor immediately. A comparison chart showing what each of these 5 conditions costs at an ER versus urgent care versus the first-line protocol. A guide to the 17 countries that use standardized first-line home protocols for these conditions as part of their national healthcare frameworks, and a section on how to talk to your doctor about integrating these approaches into your own care plan. Over 10 complete guides in one place, no filler, straight to the point. The link is in the description. But stay here. This information has been sitting in research databases for decades. Today is the day you find it. Let me give you the numbers first so you understand what is at stake. 6 in 10 American adults are worried about being able to afford their prescription medications. That is the highest number the Kaiser Family Foundation has recorded since they began asking the question in 2018. 36% of adults skipped or postponed health care they needed in the last 12 months because of the cost. Among Americans with household incomes below $40,000 per year, 41% took some form of cost-saving measure with their medications last year. 27% of Americans left a prescription at the pharmacy counter without filling it because they could not afford it. And the average emergency room visit in the United States costs $2,600 without insurance, according to UnitedHealthcare's own published data. With insurance, insured patients spend an average of $600 out of pocket per visit. 1 in 4 of those insured patients pays closer to $900. For a family of 4 in the median American income bracket, a single ER visit for a non-emergency condition can represent 1 to 2 weeks of take-home pay. And here is the part that should make you angry. The conditions driving most of those non-emergency visits are not complicated, they're not mysterious, and they are not medically untreatable outside of a clinical setting. They were simply never explained to you. If you have made it this far, you already understand this system better than most. Subscribe and share this with your family before someone in your household pays $300 for something that costs $1. The complete guide is in the description. Now let me show you what the research actually says. In 1967, the United States ranked number 1 in the world on virtually every measure of healthcare outcomes: life expectancy, infant mortality, cancer survival rates, cardiac recovery, number 1 across the board. By 1990, the United States had fallen to 15th, by 2000 to 24th. Today, the United States ranks 42nd in life expectancy among developed nations. 42nd. And healthcare spending per person has increased by more than 300% in inflation-adjusted terms over the same period. We are paying dramatically more and getting dramatically less. The divergence happened in the 1980s. That decade, a series of policy decisions transformed American medicine from a primarily care-based system into a primarily billing-based system. Hospital reimbursement shifted from flat rates to fee-for-service. Pharmaceutical companies gained the right to advertise prescription drugs directly to consumers. Insurance companies began restructuring coverage to reward high-cost interventions over low-cost prevention. And a generation of physicians trained in this new system learned that the visit, the test, the prescription, the follow-up were all separately billable events, each one a revenue line. A physician who tells you to drink more water and take a cranberry supplement this week earns nothing from that conversation. A physician who orders a urinalysis, a culture, a sensitivity panel, and writes a prescription earns between $300 and $800 for the same outcome. The system did not hide these first-line protocols because they do not work. The system ignored them because they generate zero revenue. So here are the 5 conditions, what the research actually says, and what to do before you walk into an emergency room. This is not medical advice. If symptoms persist beyond 48 hours, worsen, or involve fever, see a doctor. No exceptions. Condition 1. Urinary tract infection in otherwise healthy adult women. UTIs are the second most common infectious disease diagnosis in the United States. More than 8 million ER and physician visits per year. The first-line recommendation in most of Europe, Canada, and Australia before antibiotics is a simple intervention backed by 50 studies and 8,857 participants in the 2023 Cochrane Systematic Review. Cranberry products. The Cochrane Review, published in the Journal of the Cochrane Collaboration and indexed on PubMed, found that in moderate certainty evidence, cranberry products reduce the risk of symptomatic culture-verified UTIs across all study groups. For women with recurrent UTIs specifically, the risk reduction was 26% compared to placebo. The mechanism is documented. Cranberries contain proanthocyanidins, compounds that prevent E. coli bacteria from adhering to the walls of the bladder. Without adhesion, the bacteria cannot establish infection. The intervention: concentrated cranberry extract capsules or tablets, not cocktail juice with added sugar. Available at any pharmacy or dollar store for under $1 per dose. At least 36 milligrams of proanthocyanidins per daily dose is the threshold the research identifies as effective. Drink at minimum 2 liters of water per day, alongside the supplement to mechanically flush the bladder. What to watch for. If you develop fever above 100 degrees Fahrenheit, back or side pain, nausea or vomiting, or symptoms that worsen after 48 hours, you need antibiotics and you need to see a doctor. Cranberry is a first-line preventive and early intervention tool. It is not a substitute for antibiotic treatment of an established, complicated, or ascending infection. Condition 2. Migraine without aura. Prevention protocol. 39 million Americans suffer from migraine. The average migraine sufferer misses 4.4 workdays per year. And yet, one of the most evidence-supported preventive interventions for migraine is available over the counter at any dollar store without a prescription for under $1 per daily dose. Magnesium. In 2012, the American Academy of Neurology and the American Headache Society completed a systematic review of migraine prevention medications and gave oral magnesium a Level B rating. Level B means probably effective and should be considered for patients requiring migraine preventive therapy. That is the same evidence tier as some prescription preventives that cost $40 to $80 per month. A meta-analysis published in the journal Headache in 2016 pulled data from 21 clinical trials and found that oral magnesium supplementation significantly reduced both migraine frequency and intensity. The landmark PCART study, the most cited clinical trial in the magnesium migraine literature, found a 41.6% reduction in migraine attacks in the magnesium group versus 15% in the placebo group over 12 weeks. The intervention: 400 milligrams of elemental magnesium daily taken with food. Magnesium glycinate or magnesium citrate absorb significantly better than magnesium oxide. Check the label for elemental magnesium content, not the total compound weight. The research consistently shows 3 months of consistent use before full preventive effect is established. This is prevention, not acute treatment. If you are in the middle of a migraine attack, you need appropriate acute treatment, which you should discuss with your physician. But if you suffer from recurring migraines and have never been told about Level B evidence for a $1 supplement, that is a conversation your physician had a financial incentive not to start. Condition 3. Acute outer ear pain known as otitis externa or swimmer's ear. This is inflammation and irritation of the outer ear canal, not a middle ear infection. The distinction is critical, and we will explain exactly how to tell the difference. Otitis externa accounts for millions of urgent care and ER visits annually. The first-line interventions used widely in integrative and naturopathic medicine and supported by the antimicrobial properties documented in the research literature on allicin, warm compress, and topical garlic oil. Important honest note: the clinical trial evidence for garlic oil specifically in human ear canal infections is limited to small studies. What the research does confirm is that allicin, the active compound in garlic, demonstrates antimicrobial properties against common outer ear bacteria including Staphylococcus and Pseudomonas in laboratory studies. Warm compress alone is well supported for pain relief and promoting circulation to inflamed tissue. The intervention: a warm, not hot, compress held against the outer ear for 15 to 20 minutes, 3 times per day. If using garlic oil, 2 drops of gently warmed olive oil with a crushed raw garlic clove, steeped for 15 minutes and strained, applied to the outer ear canal. This is for outer ear pain only. How to tell the difference between outer and middle ear infection. Otitis externa produces pain when you pull the outer ear or press the small cartilage bump at the front of the ear canal. Middle ear infection typically does not cause pain with those movements, but does cause pain deep behind the eardrum, often with hearing loss, fever, or fluid drainage. If you have fever, significant hearing loss, fluid draining from the ear, dizziness, or pain that is severe, go to a doctor. These signs indicate a condition that requires professional evaluation and may require antibiotics. Condition 4. Functional indigestion and mild nausea. Not diagnosed GERD, not chest pain, not difficulty swallowing. Occasional post-meal discomfort, bloating, and nausea that millions of Americans bring to emergency rooms every year. Ginger. A 2014 review published in the British Journal of Anesthesia examined 12 randomized controlled trials and found that ginger supplementation significantly reduced nausea compared to placebo. Additional research has found ginger reduces gastric emptying time and helps regulate the muscle contractions of the digestive tract. The mechanism is documented. Gingerols and shogaols, the active compounds in ginger, interact with serotonin receptors in the gut and reduce nausea signaling. The intervention: fresh ginger tea, a 1-inch piece of raw ginger steeped in hot water for 10 minutes, or 1 to 2 grams of powdered ginger in warm water. Available at any grocery store for under 50 cents per dose. This is not a treatment for GERD, esophageal conditions, ulcers, or any diagnosed gastrointestinal disorder. If you have persistent heartburn, difficulty swallowing, blood in your stool, or unexplained weight loss, These are symptoms that require professional evaluation. Ginger is a first-line approach for functional indigestion and mild nausea in otherwise healthy adults. Condition 5. Superficial fungal skin infection, specifically athlete's foot. This is one of the most common fungal infections in the world. The causative organisms are dermatophytes, primarily Trichophyton rubrum and Trichophyton mentagrophytes. White distilled vinegar, which is 4 to 8% acetic acid, has demonstrated antifungal activity against dermatophytes in multiple laboratory studies. A study published in the Journal of Prosthodontics found that 4% acetic acid, the concentration in standard white vinegar, inhibited the growth of Candida albicans. Additional studies have confirmed antifungal activity of acetic acid against common skin dermatophytes at concentrations found in commercially available vinegar. The clinical trial evidence for topical vinegar in human superficial fungal infections is limited, and I want to be clear about that. The laboratory data is strong. The human clinical trial data is early stage. The intervention, undiluted white distilled vinegar, applied directly to the affected skin using a cotton ball twice daily for a minimum of 2 weeks. Allow to dry completely before covering the area. Keep the affected area as dry as possible throughout treatment. Fungi require moisture to survive and proliferate. This applies to superficial skin fungal infections only. Nail fungus is a fundamentally different condition that penetrates the nail matrix and almost never responds to topical treatments alone, including prescription topical antifungals. If you have nail involvement, significant spread, skin breakdown, or are diabetic or immunocompromised, see a dermatologist. Now here is the real math. The average American with a deductible-based insurance plan spends $600 out of pocket on each ER visit. For uninsured Americans, the bill averages $2,600. If the information in this video helps you manage even 2 of these conditions at home appropriately over the course of a year, you have avoided between $600 and $1,200 in out-of-pocket costs. In 5 years, that is $3,000 to $6,000 that stays in your household. The total cost of all 5 first-line interventions combined, used one time each, is under $5. That gap, that chasm between $5 and $3,000, is not a medical gap. It is an information gap. Your physician is not withholding this information maliciously. Your physician operates inside a system where each visit, each test, each prescription generates revenue. A physician who says try ginger tea and call me in 2 days earns nothing from that recommendation. The system is not structured to reward the conversation that keeps you out of the waiting room. It is structured to reward what happens after you are already sitting in it. That structure has been deliberately constructed and deliberately maintained. Save this video. Share it with your family before the next time someone in your household considers an emergency room for one of these 5 conditions. Every share is one more American household that has a first-line option before a $2,600 bill arrives in the mail. This knowledge has been in the research literature for years. The only reason it never reached your kitchen table is because your kitchen table is not a revenue line. Subscribe to Dr. Phillip's Forbidden Files. The next vault opens soon, and what is inside costs them even more.